Very good afternoon to all of you. So this afternoon session will be on spondyloarthropathy and psoriatic arthritis. So as you all know, spondyloarthropathy it constitutes a wide spectrum of diseases. Of its psoriatic arthritis also comes under this. So here the theme is real life challenges in spondyloarthropathy and psoriatic arthritis. To chair this session, I would like to invite Dr. Sarbani Rudra Sengupta from Kolkata and Dr. Carlos Enrique Toro from Colombia. The various topics will be discussed. The first topic will be delivered by Dr. Ved Chaturvedi from Delhi. So I will be talking on can we halt structural progression and SPOND, followed by psoriatic arthritis, what is new. This will be talked upon by Dr. Ashish Jacob Matthew from Vellore, followed by optimal use of biologics in resource limited setup. This will be highlighted by Dr. G.D. Chaudhary sir from Kolkata and the practice tips by Dr. Sarbani Rudra. Over to you, ma'am.
Good afternoon. Thank you very much for your kind presentation. Now I have the pleasure to present Dr. Ved Chaturvedi, who's gonna talk about can we halt structural progression in ankylosing spondylitis. Welcome, Dr. Chaturvedi.
Good afternoon, Chairperson sir. This is my hospital now. I was earlier in Army, now I'm working in this hospital. And most of the work which we did was in this hospital because that time anti-TNF in this country, large country, was available only in this hospital, Army hospital, that year 2000. But my topic is different. My topic is, can we stop the structural progression? So this answer has to be found out. This is the father and son, both work in Dubai, both take anti-TNF, and the son asked me the same question, which is the research question, that can we stop the structural progression? So that answer, let's see what is the literature says. Most of the time earlier, probably most of the studies, probably we thought there is subset which probably some people progress, some people don't progress. So there were a lot of studies was done, and now almost the jury is out that most of the cases from non-radiographic to the radiographic, actually they progress almost about in 2 years 12%. So roughly, even if you don't remember, you remember 10%. So 10% people from non-radiological, they will progress to radiological, and very rarely, of course, nowadays can do spine. But that figure you must remember that every time if you see 100 patients, 10% of the non-radiological, they will convert into the radiological. So that is the most of the studies says nowadays. Goal of the treatment, we all know about the goal of treatment, but what probably we always miss out, that the last part, that yes, we have to prevent the structural damage also, because we talk about quality of life, we talk about pain score, we talk about SDAS. The structural damage has not been taken into consideration. So let's talk whether we can stop the structural damage. Management, we all knew till about year 99, at least in this country, that how ankylosing spondylitis or SPA was managed till in 2002 roughly. The paper was published by Jürgen Braun, and around same time we already had this drug anti-TNF with us in Army hospital. We were using for rheumatoid arthritis. Around same time when 27 cases were published by Jürgen Braun, it was published that ankylosing, it works also in ankylosing spondylitis, not only rheumatoid arthritis. So around same time I had about 127 cases. And it's not that I didn't present. I was in uniform, you require a lot of permissions and this and that. I had about more than 100 cases of ankylosing spondylitis. And what we did, we presented in the forums like ACR, we presented in the APLAR. This was a presentation APLAR in 2004 in Jeju. So that was we presented our work, about 100 cases. So people were surprised. How come you from a single center, first thing, you have so many number of patients, that is number one. And secondly, how you got the drug? So both answers is that probably Indian Army is at more male people, 1.2 million. So in 1.2 million, about 100 cases on, and we had drug also. And drug was free of cost for us, for our patient. So we were using it. And we had roughly from 99 to 2007, almost about 7 years, we used in 3,000 patients. So that is a huge data from a single center, published or unpublished. Such a huge data and such a huge experience, not many people have in the world from a single center. So we had, at that time drug was more of infliximab. So we were using a lot of infliximab, and few cases we had etanercept, though etanercept was available, but etanercept was not with us. So we were using more of infliximab. But the question is, the topic is, we can control the pain, yes. When you use infliximab, you can control the pain. Can you improve the quality of life? Yes, you can improve the quality of life. You can control the inflammation, CRP comes down. Yes, everything. But can we stop the structural progression? That, really speaking, somebody has to do a good study. So that is what is my topic is, could we stop the structural progression? And how the structural progression occurs actually. Initially, it starts as an inflammation. So any process starts as an inflammation, then comes erosion. So there is an inflammation, then there is erosion, and after that is the bridging. So that is how most of the time it is like this. Can I have water? Because as it is my... yeah. So this is an inflammation. I'll take... Oh, sorry. So initially there is inflammation, and it followed by erosion, and then the new bone formation. Is it important? Suppose I give 3,000 patients infliximab, and their quality of life improves, their pain improves. He says, I don't have any problem. Then radiographic progression in ankylosing spondylitis, is it clinically meaningful? Yes, it is meaningful. It was published in Current Opinion that radiographic damage of the spine is an attractive target. It's a clinically important outcome. So not only that you are doing SDAS and BASDI, you have to have an outcome which is important, especially the radiographic outcome. And for a radiographic outcome, we all know that you have either a normal, so you have a cervical spine, or you have a lumbar spine, and see you can have a either you can have a erosion, or you can have a sclerosis, or you can have a squaring or syndesmophytes. We all see it daily. Somebody has made a good score, and that is how we have to use this score, and this is how maximum score is about 72. So if you use this score, then you can know. And if you have a good CT scan, just see this was a paper published in the Rheumatology in 2015, that a baseline, this is a CT scan, and this say we measured all these syndesmophytes on the anterior side. Earlier when MSAS was published, it was anterior and posterior. Why anterior? Because the more progress, more structural damage occurs anteriorly. So this is about 204 millimeter. See how it becomes about 250 millimeter in just 1 year. So you may see it later, but that is how the structural damage is measured. And once you measure, then it is, progression of non-radiographic to radiographic. So it does occur. It is, as I was telling, 12% in 2 years. So if you have 100 patients of this non-radiographic, in 2 years' time they will become radiographic. So it does progress, and there's a beautiful study which was published in Annals of Rheumatic Diseases in 2012 that, see, this is the radiographic and this is non-radiographic. See the ratio? Suppose this is 67 and this is 32. As the time passes, the radiographic damage increases and this ratio almost get in 12 years. So that is what I was telling, that as the time passes, the duration makes it from non-radiographic to radiographic. Most of them progress. Very rarely they don't progress. Yes, there is a subset which may not progress, but most of them. So what are the drugs we are using? We use NSAIDs. Everybody doesn't use biologics. Everybody doesn't use sulfasalazine. A lot of people are on the NSAIDs. So what is what the literature says about NSAID? The patient also asks you whether continuous we should use or SOS. You know how sensitive we are towards about the NSAIDs. Whatever current practice is a different issue, the reality is different issue, but there are studies which say that if you use continuously, this was published in 2005, Arthritis and Rheumatism, that if you use it continuously, then you can stop the structural, it does affect the radiographic disease progression. Current position of NSAIDs is something like this, and biologics. Yes, there is satisfactory evidence based on RCTs that yes, if you use continuous, there is some evidence of continuous use, and there is a growing body of evidence that particularly long-term use. So this is probably, we have some RCTs which says if you use continuously, it can be. This was published in the current rheumatology report. What about anti-TNF? We all using anti-TNF. Can radiographic damage can be prevented by anti-TNF? So this is the very interesting, that there is a cohort called OASIS cohort. Now OASIS cohort was that cohort which that time they had data where they were not using any drug, they were not using biologics, so they had natural history of the ankylosing spondylitis, what happens in 1 year, 2 years, 3 years, 4, 5 years. And when they compared with this cohort, with that cohort which infliximab was used in 2 years, they realized there is no difference if you use. So over 2 years, TNF inhibitors, infliximab, no effect on structural progression. So you use it or you don't use it. Structural progression does not stop, whether normally or with the. So that was with the 2 years. Then came a study of 8 years. That even if you use for 8 years, because Americans say no. You use it continuously, then structural progression will be stopped. So even if you do it for 8 years, structural progression will not stop. So that is how so 2 years or 8 years, probably they are working more for inflammation, and that was a study. So it surprised most of us, including us, that yes. So they say, why infliximab? Let's change the drug. So they changed the drug and started using adalimumab. Whether the same data from adalimumab comes, so surprisingly exactly same data, whether you use, if you compare with a cohort which does not use the adalimumab with a cohort which is used adalimumab for 2 years, there is no difference. So that is how the 2 years of adalimumab did not slow down the radiographic progression. So this is about the adalimumab. Then about other drugs like etanercept, same story with it. Etanercept, use it or don't use it, it will be relentlessly progressing. The MSAS score will be. So probably it's independent of the TNF. The structural progression is independent of. This was published in Arthritis Rheumatism, and same was with the Gorez with golimumab. So other anti-TNF people tried, infliximab, etanercept, so everything was tried, and people. So this table was, just look at this table, very interesting table published in Arthritis and Research in 2009, whether you use A, B, C, D. Etanercept, infliximab, golimumab, anything you use, compared with the OASIS cohort, it doesn't. The p-value is not significant. Means if you use or don't use, structural progression will go on. So that is how it is. So this is the Swiss cohort which they use. They say no, it is not true. If you use TNF, the order of progression is 50%. So it means probably there is some issues with the data that we also feel if you use anti-TNF, it is effective. Then came the other studies that if you taper prematurely, if you're using it, stop it, then what will happen? A dose tapering study, and what will happen? That will cause a more radiographic progression. It means the anti-TNF is useful. So both type of data is available. Most of the data says no, but I'll just come to this, I'll just skip this. This is a data of our own person from my own college, Harun, who is settled in Canada, which we keep saying, if you use early and use, then it will be effective. If you use after 10 years, look, most of the, I didn't have time, most of it is people are using for late disease. For 3,000 patients which you use in Army Hospital, 90% were early disease. So you have to use it early. This was published in Arthritis Rheumatism, and he says the same thing. If you use early, you can prevent the structural damage. I'll just take 2 minutes. Then came another drug, IL-17 inhibitors, secukinumab. Does it help, secukinumab, if you have a versus anti-TNF? Then came a very data, though it was sponsored by the company itself, that 80% of patients showed no radiographic progression in 2 years. So very surprisingly, use anti-TNF, it doesn't. If you use this, there is a structural, you can stop the structural progression. I have 2 minutes. So, and then the same measure one study says that if you don't have a baseline CD5, almost about, where was it? Sorry. So no, so use it for 2 years or 4 years. 80% patients who are on anti-IL-17, they will not have radiographic progression. So why it is happening? Probably these two cytokines, the TNF and IL-17, they behave in a different way. It is just last 2 slides. The TNF suppress bone formation. So if you use anti-TNF, there will be more bone, new bone formation. While IL-17, it induces bone formation. So what will happen if you use anti-TNF drug? There will be it suppresses the bone formation and it will lead to more bone formation. So that is how these studies were published, and they say TNF use causes more. Now that is one study, it has to be, and if you use IL-17, it inhibits bone formation. So to summarize, ladies and gentlemen, I call it young male. I wrote in India Today long back a story, young soldiers spinal arthritis, arthritis of young soldiers. And I all call it, for a layman, I call it spinal arthritis. Early treatment has better outcome. We know about the treatment, we really don't know. Still we don't know after this presentation, also after reading and reviewing the whole thing. I really don't know the answer of the last, stop structural progression. Probably more studies are required. More, you have to read it carefully between IL-17 and TNF. Maybe early results has to be published nicely. And who will publish it? We will publish it someday, that yes, if you use early, from 3,000 patients, almost 90%, that time this non-radiographic and radiographic business was not there. But we are convinced that we used very early, and those data has to be, somebody has to formulate and sit down. Thank you so much. Thanks.
Thank you very much, Dr. Chaturvedi, for your excellent presentation, and congratulations for your outstanding and huge amount of data for a single center. Congratulations. Now is the time to continue. We're going to talk about psoriatic arthritis, what is new. And I have the pleasure to present Dr. Ashish Jacob Matthew from Vellore. Welcome, Ashish.
Thank you, Chairpersons. Good afternoon, and it's a pleasure to be back in IRACON again after a hiatus of 2 years, meeting people, having great surprises, and of course presenting in something which you really like. So in the next few slides, I'll be just giving an overview of what's new in psoriatic arthritis. A disclaimer up front, I'm sure there'll be a lot of personal biases in which I've gone around checking the literature, and if you think that something has been missed out, kindly bear with me. So these are the relevant disclosures for my talk today. Starting off, we know that psoriasis can be a visible risk factor for developing psoriatic arthritis in the long run. And a lot of people have worked over the years to categorize the risk factors for developing psoriatic arthritis. And today we know that it's a transition, and it starts somewhere at the immune activation. At the immune activation phase, going on to subclinical phase, then you have a preclinical phase, and then a clinical phase. So that's the kind of transition. Now, this is answered by Core Evita's psoriasis registry, which used to be called the Corona registry until the real Corona struck about a couple of years ago, and then I guess they changed the name to Core Evita's, in which they had 11,000 odd patients who were pure psoriasis patients without any musculoskeletal problems, being followed up by a dermatologist. And what they did was they had a priority set of risk factors which they characterized, and they looked for, they had multiple models, 14 of them to be precise, of which 8 were kind of a LR-based model, and then 6 of them were like an elastic loop model, in which elastic network model, in which they had 14 of them, and what they the endpoint was development or diagnosis of psoriatic arthritis by the dermatologist. And what they found was 3 of the models over here, which includes 1 of the LR model and 2 of the EN, which is the elastic network models, hit a pretty high AUC in terms of predicting incident PSA. And 2 of them, which essentially means, which is EN, which included a whole lot of risk factors, and more of a parsimonious model, which is LR1, which is mostly PEST and BMI, hit pretty high 92% sensitivity. So in the development of psoriatic arthritis, probably PEST or BME and BMI could be risk factors which could be taken forward in terms of screening patients with psoriasis to develop psoriatic arthritis. So obviously the next question is, can we stop this prevention? So interestingly, there were 3 studies which came up in the last 2 years. I'll be just presenting one of them, which is from Italy, in which they did a retrospective non-randomized study on patients with moderate to severe plaque psoriasis, in which they looked at biologic DMARDs versus non-biologic or UVB phototherapy in 234 and 230 patients who were on continuous therapy for 5 years. And then they checked the incident PSA in this group and found that patients who were on biologic DMARDs, as it's there in the first row, we can see both in the univariate as well as the adjusted model multivariable analysis, they could see a starking difference, or rather a very low hazard's risk for developing psoriatic arthritis. So, again, the same group. So essentially, continuous therapeutic intervention with biologic DMARD was the authors could show that there was a reduction in incident PSA in patients with moderate to severe plaque psoriasis. The same group, the same kind of study was done by Enrique Soriano and his group from Argentina, who showed that, again, biologic DMARDs were kind of protective as opposed to conventional DMARDs in development of psoriatic arthritis. However, a similar study done in the US didn't really show much of a benefit. So the only problem is most of them are retrospective studies, so we need to have more data on that. Coming on to the burden of psoriatic arthritis, we know that psoriatic arthritis, 65%, again, this is data from Core Evita's registry in the US by Alex Zogby, in which they showed that 65% of the patients, 2,617 odd patients, had multi-domain psoriatic disease, and only 24% had single domain. And we see here on the right side that patients who had 2 and 3 domains comprised 50% of the study population. And here again, we see that patients who had higher number of domains were started on biologics earlier than those who had less than 2, essentially 1 domain, for instance, skin. Now, they also compared this with work productivity and saw that patients who had higher number of domains had less of work productivity. Also, they showed that they were more likely to have fibromyalgia, depression, and anxiety. Moving on to early identification. Now, we know that there are a lot of screening questionnaires we can use in dermatology clinics for screening patients who are at risk of developing psoriatic arthritis. Now, this is something new, a new kid on the block, which is the axial PSA, a lot of noise about it, in which, and now this is a study done in Berlin by the Charité group. Fabian Proft is the first author, in which they tried to see if they can screen patients who are at risk of developing axial spondyloarthritis by the dermatologist using a screening questionnaire. And what they found is they had 355 patients who presented to the dermatologist, and if the dermatologist felt a need that the patient should be screened for axial PSA, they had to be referred to a rheumatologist who then would do a complete examination along with an MRI of the SI joint as well as the spine. So out of the 100 who were seen by rheumatologists, 14 of them developed or were diagnosed to have axial PSA, of which 9 fulfilled the ASS criteria. A funny diagram, I thought, but this is really important because it's more of a Venn kind of a diagram in which we see a spinal inflammation of in MRI, where about 14 of them had just about active inflammation of the spine, as opposed to less numbers in the active active inflammation of the SIJ right on top. So we know that PSA or axial PSA could have more of spine involvement than SIJ, as opposed to AxSpA, where we have more of SIJ as compared to spine itself. So this study brought out the importance of a dermatology-centric screening questionnaire for screening of axial PSA in dermatology clinics. One of the papers from my PhD there in Denmark, where we did Danber registry is supposed to be one of the best in terms of complete registration of data. So this, the whole question was what's the quality of data in routine care when it comes to enthesitis? Now, we had an incident cohort which was defined as patients at their first visit, registered in Landbio in 2010 or later, where we had 681 patients out of the 6,582 patients of psoriatic arthritis. 681 had SPARC score using, enthesitis score using the SPARC enthesitis index. And however, what is surprising was 85% didn't have any data on evaluation of enthesis. So that just shows a huge gap in routine care when we talk about enthesitis. What is again surprising was comparing the male is to female, we see more of women had enthesitis as compared to men. And if you look at the composite index DAPSA 68, as well as all the patient-reported outcomes, right across the board, we can see that there was significant differences between patients who had who had enthesitis as compared to those who didn't have. In the same way, in dactylitis, this is again data from the Leeds group, in which they've shown that dactylitis itself is more severe when it comes to overall phenotype in early PSA, in which they took 177 patients who were DMARD naive patients and kind of stratified them based on dactylitis presence and absence, and also did a complete evaluation both in terms of the peripheral joints as well as enthesis, and also did an ultrasound which included grayscale, PD, and the guess for enthesitis. And what they showed is both tender joint and swollen joint were more in patients with dactylitis, significantly more than their counterparts, as well as MESIS, which was again a median score of 1 as compared to nil, and which was significant. And in ultrasound, again, they showed that PD of more than 1 was more significantly higher in patients who had dactylitis as opposed to who didn't have, and pretty much the same with ultrasound, with erosions. Now, coming to comorbidities in PSA, we know that depression and anxiety is a big thing now. Most of the patients, in fact, up to about 30 to 40%, depending on how you use the definition, have depression. This is the data from Toronto group, in which Anthony Wong showed that depression and presence of depression and anxiety, which is defined using 3 definitions, again, just showing how complex it is to define this whole thing. using the MCS, the MH, both from the SF36, as well as rheumatologist report. And we did a time to event analysis. There were 743 patients included, of which we see that close to 50% of them could have been depressed if you were to apply this definition. And they showed that depression and anxiety, the odds of achieving an MDA was just about 0.3 using the first definition, as opposed to somebody who didn't have depression and anxiety. Pretty much the same with the comorbidity as well. So that brings to the question, is all depression the same? And that's not why we are kind of getting into the realm of dimensional aspects of depression when we talk about treatment modification in patients with psoriatic arthritis. This is again a paper which is published in EULAR, again from the Toronto group, where we tried treating these just to see what is the effect of B DMARDs and C DMARDs on treating these patients with psoriatic arthritis. Again, the MCS model, the drugs used were categorized into three exclusive baskets. Category 1 was no treatment or just NSAIDs. Category 2 was conventional DMARDs plus minus NSAID. And category 3, which is the orange one, was biologic DMARDs. And we showed that there was no, if you use reference 1, which is no treatment or NSAIDs as a reference, there was no difference in any of the groups. However, if you use category 2, which is conventional DMARDs, there was an odds of 1.71 in achieving remission in anxiety and depression with biologic DMARDs as compared to patients who are on conventional DMARDs. Fibromyalgia, in the interest of time, I'll just skip again, people have shown that it has a great impact on the overall disease activity. This is again data from the PGI group. Now, what's the role of ultrasound in delineating what is true fibromyalgia from what is true synovitis or enthesitis? There's been a number of publications over the past decade in which mostly over the last 5 years, I would say. And in this one, which is again from Ari Polachek's group in Israel, where they used, where they did complete clinical examination of the patients, did the patient composite scores as well as reported outcomes, and fibromyalgia was defined both in terms of WPI as well as SSS. They also did ultrasound on the same day for the same patients, and they showed that ultrasound scores correlated total ultrasound scores correlated pretty well for patients without fibromyalgia, and they didn't for patients who had fibromyalgia. However, clinically, fibromyalgia syndrome was correlated pretty well with DAPSA, CPDI, and CASDAS. Coming to axial psoriatic arthritis again, this was again a study by Lihi Eder and a group from Israel. Of course, Lihi is in, but the data was from Israel and Toronto, where they took 93 patients and tried to see by doing MRI for all the patients. What I would like to bring to your attention is there was a high discrepancy between symptoms and MRI findings in patients who were diagnosed clinically as axial spondyloarthritis, PSA, as opposed to in imaging. And male sex was associated with, so that brings to the AXIS study, in which we are part of, the 3 centers from India. We have started recruiting patients recently. Just 40 more seconds. This is again defining imaging phenotype, again work by Lihi and Vinod in Toronto, where they showed that they could show that there were 3 distinct types of patients. One group had synovitis, another group had enthesitis, and the other group had tenonitis by ultrasound. They did a PCA, which is a primary component analysis, where they could clearly mark these clusters, and they're also doing RNA expression. This was again a study from my group in which we did if we could use MRI to distinguish between these 3 classes: rheumatoid arthritis, inflammatory, undifferentiated, and psoriasis. And we could find that there was the thumb inflammation, which was more for patients with psoriasis. Tender joint count, this is again a very good study by a very good friend and a colleague of mine from Denmark, who showed that tender joint count didn't really correlate well with ultrasound findings. Achilles trial data which just came up recently in which they applied the hemorrhage scoring system in MRI. Now, this I'll just skip in the interest of time and just come straight to the treatment aspect in which treatment guidelines have been set up by multiple people involved in this group. All I wanted to bring to your attention is the multiple domains. I'm sure you can just pick it up from the publication straight away. But here, what is more important is the number of domains in which, and the domain-based treatment which was emphasized by GRAPPA, along with a lot of emphasis on comorbidities, which is very important as we have the discussion with the patients on treatment. So takeaways, PEST and BMA could be used for predicting PSA. Multi-domain PSAs do have higher overall disease activity. Enthesitis is not really well captured in clinics. However, it has an overall high disease activity. There's poor agreement between MRI findings and ACES classification criteria among patients with active PSA. And GRAPPA 2021 treatment guidelines are out for your reference. Thank you very much, and apologies for overshooting the time.
Thank you very much, Dr. Ashish. Wonderful presentation, and congratulations for your several publications in the field. I'd like to invite both speakers for the questions. And now the time for questions from the other. The microphone is open.
So, ask them to sit here?
Yeah, I'll invite them for questions. Dr. Chaudhary.
I'm Dr. Gautam Dhar Chaudhary from Kaman Hospital, Calcutta. Sir, this is regarding I guess the Dr. Ved Chaturvedi's topic. His topic was retarding, can the biologists retard the radiologic progressions? Over the so many years, all the trials have failed. Now what has happened, this IL-17, and they have come to say that they are going to halt progression. I slightly think has to be taken with some pinch of salt. I want to draw your attention, Mr. Chairperson, sir. You must have seen from 2019 to 2022, even premium article journals like NEJM and all also come under huge criticism. Overloaded of articles and all are given. The trials have been thrown with minimum observational studies and all. In fact, to my personal experience, we are also a prime user of the IL-17. Leave aside axial spondyloarthropathy, in a psoriatic arthritis case also, if the active psoriasis is not there, I treat those patients, only active psoriasis is not there, I treat them with anti-TNFs and other. Active psoriasis, psoriatic arthritis, IL-17 is there. So whatever the tall claims they are doing, it will be the time to prove.
Chow, you are absolutely correct. Any new drug comes, they will all say that once you read it in between line, then you realize. But I always say anti-IL-17 is absolutely as effective as anti-TNF in axial SP also. I'm the probably very high user of anti-IL-17, and it started with a doctor friend of mine who flew from Mumbai. During Corona time, he had tuberculosis and he was put on duty and he was on wheelchair, and then he came that, look, after anti-TNF I got tuberculosis and now I have such a severe problem. And that is about the moment when it was launched, this drug, and he had axial SPA, we gave him secukinumab. Absolutely he was, so after that we have given 200 to 300 patients, but structural damage thing, I agree with you that yes, it is effective. Any new drug comes, you always use it with a caution. So that's why it is written in the guidelines that you use anti-TNF first, or if the skin lesions are there, or anti-TNF is contraindicated, or if it is failed, then you use anti-IL-17 as per the old guidelines. Probably new guidelines, probably Ashok is discussing in other hall what say, but probably now the new guidelines say you can use both of them. Yes, structural damage, whether they prevent or not, probably if you see that OSS cohort and those studies, 2 studies which I quoted, 10 years, you know how many years of patient they had taken? 10 years, 15 years patient. What do you expect in that? Which already damage has been done. So somebody has to publish early disease. That if you publish early disease, then you will know exactly and had to add comparison. then it can possible.
With the permission of the
Yeah.
chair, can I just make a comment?
Okay.
Dr. Chaudhary, it's a good question. I'd like to bring to your attention that recent ACR 22, we have a study in which Xenophon Barrelikos is the first author, in which they've compared TNFI and secukinumab in axial spondyloarthritis patients. And they found there's no difference in structural progression in TNFI versus secukinumab in MRI-based study. So that, I'm pretty sure it's out for publication. Maybe in a month or so we'll see the print in that. So that's
So the final
that's probably
question
the first.
answer has to come. This is not a final answer. The last slide where everybody will publish mine is good, mine is better. But if you read in between lines, then you know they are little biased, always sponsored by the drug companies, the pharma company. So you have to see more probably. Yes, ma'am.
Okay.
So in our country, the only advantage is tuberculosis, having tuberculosis or LTBI. If it is positive, then we can go for this thing. And of course, in psoriatic arthritis, I wanted to know, Dr. Matthew, do you prefer to use it? Oh, it's not there. It's not there. Do you prefer to use it, use the biologics alone or along with other drugs like methotrexate?
Clinically, I still haven't really gone beyond, but generally I don't really go beyond conventional DMARDs because most of our patients can't afford. But given a choice of using conventional DMARDs along with biologic DMARDs, certainly I do. Because recent data from EuroSPA collaboration, in which was published last year, they've shown that 10 mg of methotrexate along with adalimumab helps in surveillance, sustenance of the drug in the long term, as opposed to just giving adalimumab alone. So certainly, I generally do add a small dose of methotrexate.
And now we have for the last question, please, a very short question and short answer.
So, what we have understood with the registry data is that persistence of biologicals is the only way forward when you want to reduce the disease burden in terms of structural progression, and the point where you want to prevent a structural progression, you don't waste time in initiation of the therapy. These are the only two things that can actually help.
Absolutely correct. Probably last point is more important. Initiation, taken a decision early. If you miss a bus, then probably moment the syndesophytes one come, then it becomes very difficult. So early, we have those cohort with us. Somebody like Chaudhary who is still in army, they can use those cohort. Unfortunately, in army, the doctor also moves and patient also moves every 2 years. So it's very difficult to do any study. But if you can catch hold even 50 patients or 100 patients out of the 3,000, then you will know they are very early disease. Nobody has that data. Very early, not early, very early disease. If you can collect that data and present, it will be a okay.
I agree, Dr. Bimlesh. I think that's a very good point you brought out because studies have shown that MSAS is one of the major things for future structural damage in terms of the spine damage. So, and most of our patients present maybe, the gap is like 5 years, so so you lose precious time in starting TNFIs. That's where the problem is.
Okay, thank you very much, and congratulations again to both speakers. So we're going to continue. We're going to continue with the optimal use of biologics in resource-limited setup, presented by Dr. Chaudhary. Welcome, Dr. Chaudhary.
Good evening. Now you see, my topic will be slightly going not as per the textbooks. We were just discussing early biologics for preventing structural progressions and all. But my topic says biologics in SPA and PSA in a limited resource. That means wherever limited, where it is really required, that is the time when you use. So that is the reason, ladies and gentlemen, I have formulated my topic to speak under the 4 headlines. Before that, I declare that I don't have any conflict of interest. Inadequate response to conventional regimens, which around 99% of the patients are all throughout the country. Then, whenever the conventional regimens after using, if there are side effects or if there are any contraindications to the first line therapy, then we can think of the biologics. We all all throughout the day, in all the national and the international conferences, we are listening that the advantages of the biologics, which I'll highlight in my only 4 lines, and was the present scenario. So what's the inadequate response? Inadequate response is either due to the drugs, mainly the NSAIDs or the DMRs. And as we know, we cannot just use a NSAIDs and after 7 days you throw out the NSAIDs. You have to use one NSAIDs in optimum dose, in the maximum dose, a minimum period of 3 weeks. If there is no response clinically or through all other meteorologically, then only you can do. That is, and once you have tried with one NSAIDs, then you switch over to another NSAIDs, then you say that there is no inadequate response. Same with the DMRDs. DMRs, inadequate responses is that normally DMRs we don't use for axial disease. It is mainly for the peripheral arthritis or a psoriatic arthritis. When the psoriatic arthritis, not DMRs, psoriatic arthritis with psoriasis, again the DMRs. And there also if there is an inadequate response. So this is the inadequate response. Then inadequate response, if the diagnosis is in doubt, first is that a lot of LBA comes with you. He has got an early morning stiffness, he has got an afternoon stiffness, he has got an evening stiffness or something or the other. And nowadays of the non-radiographic and the radiographic, if you really make them also an ankylosing spondylitis diagnosis, and if you give them NSAIDs, DMRs, they will not respond. So first, the diagnosis is in doubt, then also you can get an inadequate response. You prescribe a drug, he gets out from the market or he's been supplied, he takes it for 4 days, his relatives, his peer view, you are taking an NSAIDs, your kidney will get knocked off, you will get gastritis, he gets gastritis, he leaves the medicines, no doctor, I am okay. So poor compliance, he is poor compliant, but which has been shown to the world is that inadequate response. So these are the 3 main criteria for the inadequate response, but then we have to think some alternative. Now, unable to use the conventional drugs, that all we know that there is a lot of controversy. All our patients, they have got multiple other comorbidities. Suppose some has got the renal disease or kidney disease or a GI disease, you really cannot use the NSAIDs. Somebody has got reactions to the DMRs like sulfur drugs. Somebody has got a TPMT deficiencies to azathioprine, not in this construct for others. So a lot of other complications. That is the time we have to think what are the other alternatives. Side effects in biologics, giving a first dose after infliximab or anything, there is a huge reactions are there. I still remember when we used to buy the biologics at a very high cost, the day I have to give one infusion, I used to put 2 patients on the bed. And first in infusion, I have to give inject 100 ml. Then slowly around for half an hour, if it is in reactions, that is stopped and the other patients again cannulated, we give it to the patients so that at least the drugs are no loss. So with the biologics also, we have reactions. So that is the time we have to think others. Now we all know what are the advantages of biologics. In spite of our limited resource setup, we all know this is the treat to target, because now it is the era of non-radiographic axial SPA. We don't have to wait for the sacroiliitis. Then it rapidly controls the underlying inflammations. It improves the quality of life. Nowadays everybody wants to know the quality of life. That is the reason more from the vial based, we are having the PFS based. A patient don't have to go to hospitals. He will sit in his hotels or in his office and will self-inject the PFS. And achievement of drug-free remission, this is $1 million question. Second, with the advantage of the biologics, with sulfasalazine or indomethacin, every 3 monthly HB, SGPT or a serum creatinine. No, with the biologics, you don't have to do any serial investigations. 2 studies just I thought I will just mention in this brief way. This is one study published in 2022, treating the skin with biologics in patients with psoriasis. They decreases also the incidence of the psoriatic arthritis. So they came to conclusion that biologics in patients with psoriasis reduce the risk of PSA development. But when slightly I went inside the study, they have found the result was comparable with the topics, with the topical whatever they are using along with the biologics, but not with when they were using the conventional DMRs. We have a study from our Calcutta and India, and very usefully done by our madam who is the chairperson. They studied whether instead of daily serial regular regimen of using axial infliximab, can SOS basis axial SPA can be given. So maintenance of doses in patients with ankylosing spondylitis. And they found that initial induction and an on-demand of MD regimen of infliximab based on BASDAI were associated with significant improvement in the disease activity and the quality of life. Present scenario, when we bought infliximab, it was 42,000. Nowadays, the main parent drug come at 30,000 Indian rupees, sir, and the biosimilars have become much more cheaper. Second, so that is the reason, and with the insurance company and the state and the central government also giving out, it has become a bit of affordable. There is an increased awareness. In our country, it is very easy. The patient goes for, he may not know the ultimately what is the economic burden of the biologics he is going to have, but he don't mind paying 600 to 1,000 rupees and go to 5 rheumatologists, writing adalimumab, infliximab and all, and they come to us. Sir, why you are only giving me NSAIDs? Why you are only giving me NSAIDs and SSJ when someone has written adalimumab, he has written golimumab, he has written... So increase the awareness of the patients, that is also taken, has to be considered. So finally, I conclude my topic this evening, ladies and gentlemen, with the key messages. The conventional drugs are preferable unless there is lack of optimum response or the side effects. Biologics are now the key player, especially in SPA. In SPA, where there are no traditional DMRs, is still not able to make any inroad. Only NSAIDs, oblique anti-TNF. NSAIDs, a poor man's anti-TNF. And there is significant reduction in the cost and increase in the patient awareness to receive the best therapy that has made the biologics popular. Thank you for your patient hearing.
Thank you very much, Dr. Chowdhury. Now I have the pleasure to present my co-chairperson, Dr. Sarvani Rudra Sengupta from Kolkata, for the closing remarks and the practice tips. Welcome.
Thank you, Chairperson, and my respected previous speakers. And after you heard this lucid delivery by Dr. G.D. Chowdhury regarding this optimal uses of biologics in resource-limited setup, that was the key practical points I have to discuss within 5 minutes. And because we come from a central government institution, though we are not resource limited actually, but we have to fight with other departments to get our piece of meal. Biologics actually need a lot of money, and there is increasing demand from our patients. So, and biologics are used by many departments apart from our rheumatology, like dermatology, like respiratory medicine. Everyone is using biologics now. So I was thinking how to get my patients, this increasing demand of biologics, how to get my patients involved in that. Because there is a long process of indent, then supply, then we are losing days. So I went through all the literatures, and previously also and now recently, several literatures, those mostly are international, they have showed this cost effectiveness and they have compared with other CDMRs, and they have showed that that the proportion of patients who were on biologics at 12 months was 69%, and tapering of doses was 73%. Then tapering of doses was 69%, then non-tapering doses 73%. And also treat-to-target strategies with the TNF tapering doses were attempted in several literatures, including psoriatic arthritis as well as spondyloarthritis, and they showed that results were non-inferior. Hence, I thought of taking this study up. And as Dr. G.D. Chaudhary has already mentioned my study, that I have taken this on-demand therapy. Like after the initial induction dose, my study was only on infliximab at the time, because that was very much costly. So I had to rationalize, I had to ration with the optimum uses. So after the initial induction doses, and then I, depending on the bus diet, quality of life, I increased the duration. And I was at the end of the 6 weeks of the last dose, there were, we compared with the baseline, and bus diet 40 scores were achieved 100% and 92% in these patients respectively. In support of my this study and my practice, I started practice this. I started, this study was on 50 patients, but till now I'm practicing this because of the constraints of this getting or procurement of the biologics with increasing demand in patients. And in support of that, there are not many studies, Indian studies I found, but one study from Vellore, Professor Danda et al., they have also showed that they have not compared with biologics, but they have shown that this axial spondyloarthritis, where biologics is the only solution, but the methotrexate and sulfasalazine was equally efficacious. So in a resource limited or resource constrained setup, we also have to think of that. But uses of biologics, as Dr. G.D. Chaudhary has already nicely mentioned, is a demand of the day. But we have to judiciously use it, optimize the usage, and for the administration also, there is an urgent need for these Indian studies on health economic outcome research and cost effectiveness models for justifying the policymakers' opinion. This comparative data allow the key decision makers to allocate the budget appropriately, and hence we can also show our administrators that yes, depending on this, we can use the biologics regularly, and we can continue the treatment for a long period. Thank you.
Thank you very much, Dr. Gupta, and thank you to all the speakers. Now we can close the session, because in order to follow the time. Thank you very much to all of you.